about are diabetic complications. Perhaps one of the most life-threatening complications that can occur is diabetic ketoacidosis. Diabetic ketoacidosis, otherwise known as DKA. Pretty much follows the name. Diabetics, ketoacidosis, ketones in the blood, ketones spill out in the urine, and they acidify the body. Maybe you want to put it like that. Basically, the ketones acidify the body to pathological levels. Acidosis. Okay, let me describe the clinical picture of diabetic ketoacidosis. And we can look at the labs. Look at the labs here. And the patient will have an abnormally high blood glucose level, 300 milligrams per deciliter or greater, 400, 500, 600, 700, whatever, way up there, okay? And remember, the problem is the insulin is not working. The insulin is not working if there is any insulin. And bottom line is the sugar level keeps on going up and up, but it can't be used. Can't be used, okay? Can't be used. So the body's resorted to breaking down fats, otherwise called lipids. And this breaking down lipolysis. And what happens is ketone bodies are liberated. All right, when these ketone bodies get in the body, and spread through the body, if you will, acidosis follows. All right. Okay, bicarb level goes down. Anytime a patient becomes acidotic, bottom line is the bicarb there is trying to neutralize the acid, bring it up to a safer level, but there comes a point when there's not enough bicarb. So they get depleted of bicarb stores. So the bicarb level is less than 15 MEQs. Normal is about 22 to 26. Okay. pH, not written up here, but the pH level will be below 7.3. Remember our arterial blood gases. What is a normal arterial blood pH? About 7.35 to 7.45. 7.35, 7.45. In this case, they're acidotic, it's going to be below 7.3. Okay? We're going to have to monitor the potassium levels. We'll get a little bit more into it, but I thought I'd throw this in here. Normal potassium levels is about 3.5 milliequivalents to about 5.1. The potassium will be the #1 electrolyte to monitor during a diabetic ketoacidotic episode. To a lesser extent, sodium. Just remember what the normal sodium levels are, about 135 to 145 MEQs per liter. Okay, those are some of the lab values. Let's go over and just look at diabetic ketoacidosis in general and see how we'll approach this clinically very dangerous situation. All right. We're going to remember that when the patient has diabetic ketoacidosis, basically their life is in balance. With no intervention, basically the end is they will die. They will die. Now, we don't want that to happen. And so what are we going to do after we identify the fact that the patient has diabetic ketoacidosis? Well, we're going to keep it simple here. Three-pronged approach. Three-pronged attack, if you will. We're going to look at three major areas to work on. They will be dehydration, they will be electrolyte imbalance, and acidosis. Let me just clarify that one more time. Dehydration, electrolyte imbalance, acidosis. Those are the three areas that we're going to work on. All right. First and foremost, we're going to have to deal with the dehydration. That ranks #1. That's the #1 first thing that we have to do is immediately rehydrate the patient. We might do well to think for just a moment, why is the diabetic ketoacidosis patient dehydrated? Well, remember, tachypnea, breathing fast. What happens when we breathe fast? We lose water vapor. Remember those insensible water losses? There you have it. Vomiting. Remember what happens to the patient in DKA, they have abdominal pain, nausea, and vomiting. Lose a lot of water that way. Also, polyuria. You remember our 3 Ps? Polydipsia, polyphagia, polyuria. Lose a lot of water. Hey, this is going to prune them out if you want. Prune them out. They're going to be dehydrated. Now, knowing that we have to rehydrate them immediately, knowing that we have to embark on fluid resuscitation. What IVs are we going to use? How much? What will be the nature? Well, here we go. You're going to rehydrate them with IV normal saline. Remember, normal saline, isotonic, 0.9%. 0.9%. One of the most familiar IVs in clinical medicine. All right? That's what we're going to use. However, occasionally we might have a patient with diabetic ketoacidosis who has congestive heart failure, who has hypernatremia, a salt level above 145, or they have hypertension. The consideration here will be an IV with salt, but half the amount of normal saline. Look at here. Normal saline, 0.45. 0.45. What's half of 0.9? 0.45. Hence they call it half normal saline. All right. How much IV? To what extent? Well, within the first hour, we're talking about 1,000 milliliters of IV fluid. That's incredible. 1,000. In the next 24 hours, we're talking 2,000 to 8,000 milliliters. Obviously, it's going to depend on the patient's status. But we're talking about a lot of fluids, IV. All right. A little bit of caution here. Caution in the older patient. In older patients, you have to be a little bit cautious. With every patient, but in the older patient, even more so. Do you remember those little crackles? The moist sounds in the lungs that we hear? You know, not bad to listen to. It's crackles. Those moist sounds, when you hear them, fluid overload. All right. I will get back to this in just a moment. But let's talk about electrolyte imbalances here. Electrolyte imbalances. And you see the glasses? Potassium level. Hey, this is it. This is what you're going to look at in diabetic ketoacidosis. The minute you hear diabetic ketoacidosis, besides fluid resuscitation, you're going to think about the ways, the schemes of potassium. Because it's very interesting. In this course of treatment, the potassium is going to go up, and then it's going to go down. All right? And a wise nurse who knows what's going on will know what is going on and will be able to not be taken by surprise. Okay? So, what we have here is transient hyperkalemia. Remember transient? You know, here today, gone 10 seconds, or just real quick, transient, real quick. Okay. Transient hyperkalemia. So, initially in DKA, the potassium level's up. All right, greater than 5.1 MEQs per liter. That's the initial phase. Part of the reason why that potassium's going up, if you remember, one of the compensatory mechanisms during acidosis is potassium, the major intracellular ion, potassium, will go out of the cell and go into the blood. And remember the hydrogen ion? The hydrogen ion, which was causing the acidosis, will sneak into the cell. So it will sort of lower the acid level. Okay? So when a patient's acidotic, we kind of expect hyperkalemia. Okay? All right. So, but this is a transient. DKA transient hyperkalemia. Okay, then they're going to go to hypokalemia. Hypokalemia, a potassium below 3.5 milliequivalents. Now, rehydration, urine output, those are going to be some of the things that lend the situation to hypokalemia. Let me take a look up here though. You may not be able to see this, but 3 points that trigger hypokalemia in a patient with diabetic ketoacidosis. Well, you rehydrate the patient. That is one of the triggers. Urine loss. The potassium goes out with the urine. Insulin also. Now, I want you to remember this, folks. One of the treatments, even for hyperkalemia, if you remember, besides KetoAcidosis, is IV administration of regular insulin. Why? Well, what the insulin does, it has a way of pushing, if you will, the potassium back to its home in the cell. Okay? All right. You remember that the potassium in a cell is about 10 times more than what it is in the blood. Okay, so those are 3 triggers there for hypokalemia. Now, hypokalemia is a life-threatening problem in and of itself. And the big thing here is dysrhythmias. Remember your conduction of the heart, SA node, AV node, bundle of His, right and left bundle branches, Purkinje fibers. But the electrical pathway of the heart is contingent upon electrolyte stability. I mean, you have to have the right amount of potassium, the right amount of sodium. You remember the sodium-potassium pump? Also, calcium plays a role in this. With that in mind, if a patient has sudden, if you will, or onset of hypokalemia, we have to worry about a life-threatening situation called dysrhythmias. Dysrhythmia. So it sounds to me like this patient's going to be on monitoring, EKG monitoring. And by the way, when a patient has hypokalemia, okay, below 3.5, 3.3, 3.2, what medicine do we not give? Do we hold or tell the doctor? Digoxin. Remember, low potassium level and giving digoxin is a recipe for dig toxicity. Just thought you should know that. All right, so we went from transient hyperkalemia, and then after we initiated the IV, and if I may say the insulin drip, which we'll talk about, all of a sudden the patient's going into what? Hypokalemia. Hypokalemia. So much so that we're going to administer IV potassium. And that is done exceedingly cautious. Very cautious, okay? Very, very cautious. And so much cautious that, remember, we don't even start IV therapy of potassium until we know for sure that we have kidney function. We have to make sure that the urine output is established before we initiate IV replacement therapy of potassium. Now, we have to talk about acidosis. Acidosis. And if we can remember, folks, remember that in acidosis, in this case, in diabetic ketoacidosis, they seem to put this number on there, a pH of 7.3. And what the patient, how they're going to approach the problem here is an IV drip of regular insulin. An IV drip of IV insulin carefully, carefully, carefully monitored. Okay? This is going to be going on for a while. And this is going to start to bring down the blood sugar levels real quick. All right, we're talking an hour or two, maybe 50 or 70 points in an hour. Okay, that's the regular IV insulin drip. Now, what is the good news about the insulin drip? Well, and the problem with DKA is glucose uptake. In other words, the cells are not picking up the glucose because there's no insulin. Now you give the insulin, and the glucose is able to go where? To the cells, so they can make energy. Yeah? All right. And when that starts to work, then there's no need to start breaking down fat. So we should see a decrease in the ketones. Now for a very critical point. You need to remember this number. When the blood glucose levels reach a point of 250 milligrams to 300 milligrams per deciliter, it's a change, it's a new strategy in the course of therapy for the DKA. So let me just repeat that in case we forget. With the insulin drip, when the patient reaches a level of about 250 milligrams or 300 milligrams per deciliter, the glucose level, we now continue with the insulin drip. However, we introduce into the IV dextrose. How come? Well, one thing we don't want is another problem to emerge. And what could that be? Hypoglycemia. Hypoglycemia. Blood sugar's going below 70. No need for that to happen. So what we'll introduce? Dextrose IV begins, avoiding hypoglycemia. Let me just turn back over here if I will. I have written here, in course of IV administration, when glucose levels approach 250 to 300 milligrams per deciliter, hey, first that's good news. Dextrose introduced. Perhaps it might be something like D5 half normalcy. Okay, there you have it. But when the patient's blood glucose levels start to hit 250, 300 milligrams per deciliter, we might at that point call the doctor and see how he's going to manage this out, and what IVs and so on. All right, so that 250 to 300 milligrams per deciliter, very critical point. Well, again, reiterating here, what is going to be the treatment strategy for diabetic ketoacidosis? Well, we're going to treat dehydration first and foremost. Got to get the fluids in there. Fluid resuscitation, number one. electrolyte imbalance. What we look at, we're going to look at those potassium levels. And what we're going to do is we're going to watch for the roller coaster effect. Remember, the potassium level has transient hyperkalemia. There's the roller coaster going up, and then it goes down, hypokalemia. All right? And we're not going to, at this point, we're not going to discuss so much the normal saline, the sodium levels, but that can be an issue. And also the patient's going to be on a what? Insulin drip. By the way, may I mention that the insulin drip will continue not only until the blood glucose levels are stabilized and normal. No, it has to go longer than that. And it will go until the bicarb level reaches a 15 to 18 milliequivalents per liter. So we may think, oh, blood sugar level is normal. Oh, now we can stop the regular IV insulin drip, if you will. No. What's the last we have to look for? At least as nurses, we're going to look at what? Bicarb level. Kind of like the last thing to get solved. Okay, the last problem on a test to get right. All right, now I have written over here, when lab values are normal and patient is able to eat, then the patient will go on sub-Q insulin and will discontinue the regular insulin IV drip. Okay? Again, before I go over there, when the glucose levels approach normal or are normal, do we stop the IV drip of insulin? No, not until the bicarb levels are at 15 to 18. Okay, we got to concern ourselves with the acidosis. Okay, let me give a little bit of a summation here. Summation, remember dehydration, we're going to treat with aggressive IV therapy. Electrolytes, what are we going to monitor? The potassium levels, maybe to a lesser extent, if you will, the sodium, but check everything. And remember the roller coaster effect with the potassium. There's a transient hyperglycemia, and then there's a sudden, if you will, or the onset of hypokalemia. And remember, when they're at 250 to 300 milligrams per deciliter and they're on the regular insulin drip, it's a switcheroo, and that's when we introduce the what? The dextrose. We introduce the what? Dextrose into the IV. All right, there you have it, and there's a lot more to learn on diabetic ketoacidosis. Kind of a sweet subject if you want to, excuse the pun, but there you have it. Thank you for listening.